Everyone you ask will have a slightly different approach to how to incorporate ultrasound into their practice. For me, yeah, FAST is foundational, trauma is foundational. I will expand that to shock. Um, Anyone in cardiac arrest comes in unconscious, pulseless, low blood pressure, tachycardic, tachypnic, so shock, I'll expand it there. But there's a lot more other areas of utilization that different people will find.
Hey, I'm Jim Wiedrich. Every day I'm working to transform healthcare in Southeast BC. One of my big ideas is to gather conversations with people who are providing the care or receiving the health care in our neck of the woods and brainstorm to see how we can make our system better. So today I'm really excited to be joined by a fellow emerge doc from our local hospital, Kevin Fairbairn. He's got a unique educational background and a fascinating focus in his career work on hands-on ultrasound. And I want to hear from him all the different applications and specific things that he sees in the future for that very specific emerge focused opportunity. Hey Kevin, I'm really glad you're with me today.
Hey, Jim, thanks for having me.
Tell the folks, if you would, how you got to Nelson and what it's been like on your medical journey so far.
Yeah, absolutely. Bit of a different journey for me. My background was initially in music. That's actually what I studied in undergrad. But behind all that, I mean, ever really since high school, I've always really loved the sciences. So I kept doing science courses, undergrad, postgrad, and that led me through to medical school. And in medical school, really enjoyed the diversity of family medicine. And I was at the DLAC program with UBC studying there. And that's where I got my first exposure to acute care medicine. Well, not first exposure, but really more comprehensive exposure, I should say. Coming from a musical background, I didn't really have the most confidence in my clinician skills, so I didn't really feel that I was up to the task of providing acute care medicine. But the more exposure I got to that field, I felt my confidence grow and felt that I could actually do it. So that actually led me through to a +1, is what it's called, an extra year in emergency medicine training. And then following that, a 9-month fellowship with UBC as well, doing specifically point of care ultrasound. After working in the Lower Mainland, my wife and I ended up moving to Nelson. She's an obstetrician, really like the group here, and I'm just incredibly grateful to be part of such a fantastic community. Really, really, yeah, happy. It seems like it's such a good fit.
Well, we're certainly stoked to have you as a doc, as a colleague, and just a good spirit in our department. Appreciate you for all that. Now, I know that, you're able to teach us lots from your vast experience. Another role that you have is as the lead for UBC rural faculties and all the hands-on ultrasound continuing medical education. Fill us in on what that all involves.
Yeah, it's one of the interesting things I found going into medicine and developing a medical career. And Jim, you know a lot about this, is that you get different hats as you go through. And so one of the hats that I was able to put on is this medical lead for this ultrasound course. It's with UBC CPD. It's called the Hands-on Ultrasound Education course stands for House. It's actually initially set up by our friend and colleague Tandy Wilkinson. So very grateful to grab the baton from her and keep running. And the idea behind the course is to provide ultrasound education primarily for rural practitioners. And the focus is really to do it from an adult-centered learning perspective as opposed to a top-down approach. So it's been a lot of fun doing it. And what we do is teach ultrasound to predominantly rural communities across British Columbia.
So when you're sharing right there, I'm thinking about another hat that I have, and that's as the physician representative on the Kootenay Lake Hospital Foundation Committee. And currently we're running the Light Up the Hospital fundraising campaign for December, and the goal is to get an advanced ultrasound machine in the diagnostic imaging department, very specifically for echocardiograms. That's looking at heart ultrasound and heart anatomy, but it also has the potential to do all the other ultrasounds, whether they be obstetric or abdominal or renal or pelvic, all the things that you or someone else in your circle of influence might have had. And I was speaking to that and trying to gear up enthusiasm for fundraising. But could you share with folks how you see the similarities or differences from what you do with hands-on ultrasound and what kind of ultrasound machines we're fundraising for that kind of campaign?
Yeah, absolutely. It's a very important distinction. We talk about diagnostic ultrasound or point of care ultrasound. Point of care ultrasound is done by the providers. So typically in the acute care settings, emergency physicians, but you can also do it in primary care, GPs, nurse practitioners, midwives, obstetricians. And what it is, point of care ultrasound, is you're using an ultrasound to answer a clinical question directly. And it's usually a yes/no question, and it's supposed to be an extension of your physical exam, and it's supposed to be relatively brief. This is very different to your diagnostic ultrasounds, which are far more detailed, require a higher level of expertise and interpretation. It's interesting because there is some overlap. We can do very similar things. You mentioned the echocardiogram. I can generate echocardiogram views at the bedside doing point of care ultrasound. I can do very, very similar things, but I'm asking different questions in a different clinical context and not getting the details that are achieved with the diagnostic scan.
So, what would you say the most frequent things you use it are for? I mean, not to steal your thunder, but like for me, the number one thing is for trauma assessments. I get out the ultrasound machine, and within the first minute, I've looked at 6 points, and I've gotten some key details that I need to know as to how to approach that trauma patient. Where do you see the different zones of application?
Jim, you're going to get me into trouble on this. I could probably talk for like half an hour just on this. Absolutely. So you hit upon the first part, trauma. The EFAST, as it's called, extended focus assessment of sonography and trauma. That's where POCUS and point of care ultrasound was really first developed. That's where the primary first literature came out supporting its use, and it's incredibly helpful. Absolutely. So that's one of the big ones, and that's more sort of the foundational. So it depends. Everyone you ask will have a slightly different approach to how to incorporate ultrasound into their practice. For me, yeah, FAST is foundational, trauma is foundational. I will expand that to shock. Anyone in cardiac arrest comes in unconscious, pulseless, low blood pressure, tachycardic, tachypnic, so shock, I'll expand it there. But there's a lot more other areas of utilization that different people will find. For me personally, I, for whatever reason, really enjoy scanning the abdominal scan when looking for bowel obstruction. So I'll rarely order plain film abdominal x-rays anymore at all, and I'll rely predominantly on my ultrasound. As we know, though, your gold standard is going to be your CT scan, and I will be getting that, of course, but I won't be ordering the x-rays anymore. So many applications. The other one that's really, I find is really helpful is the pulmonary scan. And the reason behind that is that there's no actual diagnostic equivalent. You can't send someone to diagnostic imaging to get a pulmonary or a lung ultrasound. It just doesn't exist. But there is a lot of information that we can get at the bedside immediately in the middle of the night by performing a lung ultrasound.
So, where's the future going? What's around the corner in the neighborhood of hands on ultrasound?
Good question. There's always going to be new scans that are developed, and a lot of what goes on with the new scans is you need to have the competency to do that. And a lot of that takes training and time. One of the examples for me is scanning for temporal arteritis. And you can use POCUS to do that, but in terms of myself doing it and just plopping a probe on, it's not really doing the patient any favors because I don't have the hours and training behind it. You really need to have 100 plus scans to be able to do it with any competence. But there's always going to be new scans developed, so it's definitely important to keep an eye out for. In terms of the future of point of care ultrasound, there's two big topics for me that I think are going to be we're going to be moving towards in the next 10 to 20 years. One is AI, as much as I cringe to say it, because I'm still trying to work out my own personal relationship with AI. And then the other one is chart documentation. And what I mean by that is having your ultrasound attached to the chart. So we have that with diagnostic imaging where we order an x-ray and then the x-ray, there's like a link, it's on the chart. You can see the x-ray, you can see the report, but that doesn't exist for most facilities in terms of your point of care ultrasound capabilities. There are a couple places where it is actually happening right now, something called QPath. I think they have it in Western. But in terms of integrating that, especially here in British Columbia, this is going to be decades away. But as soon as we can get that ultrasound image on the chart, I mean, it would change my practice immensely. I would order far less scans.
AI is just like the two most popular letters in the alphabet now, eh? AI.
Yeah, and that's the thing is it's not only is it coming, is it's here. With the handhelds, with a number of handhelds, there are already AI packages. And what's important to remember about point of care ultrasound is that there's two general components: image generation and image interpretation. Image generation is the hard part. That's where you're putting the ultrasound on the patient, moving it in certain directions to develop an interpretable image. As far as point of care ultrasound goes, the interpretation is usually pretty easy. A fast scan, is there a bunch of black hypoechoic free fluid where it shouldn't be? Yes or no? And so for AI, they're doing both. The GEV scan has a package that can do some interpretation of ejection fraction from your cardiac views, and it can also highlight your view and tell you whether it's an image that can be interpreted and give you suggestions on how to rotate your hand or move your hand in terms of image improvement. So they're already doing both, and it's quite remarkable. And ultimately, it could, take my position as an educator, which would be great.
Whenever I've taken ultrasound courses, it was so much of when to use the tool and then how to really properly apply it. There was a lot of teaching and learning that went on those key focus zones.
Yeah, it's that clinical context that will not be replaced easily, if at all. But it's surprising how much the artificial intelligence is capable of, really.
So, how do you see hands on ultrasound for rural communities in the future?
Yeah, excellent question. It really is dependent on the practitioner and the community. Point of care ultrasound will help you out as much as you want it to. Touching upon the pillars of healthcare that you mentioned in your first couple talks, patient-centered and timing, point of care ultrasound bridges the two. I do really strongly believe it is the best for patient care and patient-centered care is using point of care ultrasound, but there's a bit of trade-off in terms of timing. It takes a little bit longer, especially the uptake in the beginning. So some smaller communities struggle with that. Why am I going to adopt this when it's slowing me down and making me take a little longer? But it depends on needs. I'm just going to throw them under the bus or above the bus. I don't know where it is. flagship communities is Haida Gwaii. And you can understand why. They're so isolated. To get high quality imaging, it's often a ferry ride, 8 hours each way, very isolated. So they rely on ultrasound a lot, and they've become these local rural experts where they're highly proficient in their scans. And it started just off as a couple courses, and they really took it upon themselves to become experts. And it's immensely changed what that community is capable of in terms of providing timely care for the patients, picking up life-threatening conditions, DVTs, PEs, appendicitis, like all sorts of things that they're able to get ahead of the game on, as opposed to waiting for a transfer on a condition you don't know much about.
Well, I mean, like stories like communities of the likes of Haida Gwaii are such feel-good stories, and I can see how that's definitely transferable to lots of other remote and rural communities across our interior. So bring me and our audience up to speed on what kind of like price tags we're looking at here. Like what kind of capital equipment costs do we have when we're talking about these technologies?
Yeah, so there's a couple different directions for departments that are within the hospital. You typically have your cart-based machine. These are tens of thousands, on the orders of, 60, 70,000, something like that. Very expensive. But what's changed in the last 5 to 10 years is the prevalence of these so-called handheld devices. And in terms of cost for them, they're ranging from, I'd say, like 5 to 8,000 roughly. So coming down in price, and certainly over the next few years, I think that trend will continue.
So kind of like consumer electronics, the technology gets better and the price goes down.
Yeah, and one of the reasons behind that is there's two models. One is based from your isoelectric crystals, which is how your traditional ultrasounds work. It's how the images are generated. But there's a company, Butterfly, that's come out with what's called chip-based technology. So they've done away with the crystals altogether, and it's all just a computer. And like that, any sort of computer-based technology, it's generally easier to get cheaper as the years go on and the technology develops. One of the sort of knocks on it was, at least in their first few iterations, the image quality wasn't quite as good, although they just came out with their newest model in the last, I'd say, 6 months now. I've never used it personally, but I've heard it's quite good. So it's getting comparable and slightly cheaper, but I would expect it to become more affordable as the years move on.
So I understand you've got your own handheld device there. And for those viewing this podcast, I'd love for them to be able to have it demonstrated. Just play a little show and tell.
Yeah, absolutely. It's very close. It's handy. It's right in my hand.
Julio.
Well, this one's not actually mine. Working with UBC CPD, we actually do have a handheld loan program. So if you're interested in trying out different handhelds and you work in British Columbia, you can get in touch with UBC CPD and our ultrasound program, and you can try out different handhelds. So there's a number of options out there. The ones that I'm more familiar with are the Butterfly, which I mentioned, the Vscan Air, which is a GE model, which I think I briefly mentioned. Lumify Philips is one, and then Clarius is this one. Um, there we go. Clarius is a BC company. And in terms of the size, you can see it's not too much bigger than my phone. And we have one of these models in our emergency department. This is a slightly newer version. One of the trends that these companies are going to is what's called a dual probe. The Vscan Air has two probes, one on this side and one on this side. So they'll do like a linear and a curved linear. So linear is a high frequency for shallow images, and a curvilinear is for deeper images. This Clarius is called the PAL, P-A-L. It's phased array linear. Be a bit hard to see here, but you can see it. So there's actually two probes on the head. This is a linear probe here, and this is a phased array for generating cardiac images.
And in terms of the images, like the squiggles on the screen, can we see some of those?
Yeah, what does a point of care ultrasound look like? It's one of those things that I find with my patient interactions, I really enjoy showing patients what I'm looking at. I mean, of course, it takes some training to interpret these fuzzy gray lines. They don't necessarily know what they're looking at, but with some explanation, they can get it. And it's nice for them to see at the bedside. They can see, oh, that's where my arm is broken. That's where my pneumonia is. Like they can actually see it, which is nice. So I'm just going to fuddle around with my curtains here, and we'll show you guys what it looks like.
Well, on my shifts, I definitely notice a trend that when a patient has a passenger on board, so pregnant, they love to see the scanned images. And not everybody's Tom Cruise and has a ultrasound at home. So if they're in the hospital for any particular reason, it's cool to be able to show folks some images in real time.
Yeah, absolutely. That's one of my favorite applications as well.
And so as far as device size, about iPad is what I see.
So this is an iPad, but when I'm typically using this, I'll use my phone. It's just a little bit easier that way. So what we're looking at here is I'm using the linear probe, and I've put in the center of the screen, you can see a black circular structure that's bouncing, and that'll be my radial artery. And I can make it a little bit evident here and even put color on if you like as well. There you go.
I'm having a flashback to one of the first major courses that I took 11 years ago in Las Vegas to learn how to properly use hands-on ultrasound. And I remember talking to some of the instructors who were all younger, and they were showing us how to do central lines, so putting IVs in the biggest of blood vessels. And we were using the ultrasound to do all the guidance. And some of us older folks were saying, well, we learned by anatomical landmark. We had to put it in without an ultrasound machine. And they were just like kind of taken aback, like, ooh, how did that even happen? And I'm like, well, it hasn't always been this way. So I'm kind of wondering, were you just right from the get-go in your educational journey going straight to using ultrasound technique to do many of your procedures?
It's interesting. I mean, from a procedure standpoint, in my career, yes, but at the beginning of my career, I had to learn the landmarks. They were still teaching the landmarks, and I still had to learn the landmark approach to a lot of the procedures, upper extremity blocks, even central lines. They did teach us how to do it. We always used ultrasound, at least like when I was on rotation. And that certainly, I think, will be moving forward, particularly with things like central line. But procedurally, yeah, absolutely. The things I'm able to do in the emergency room, severe hand laceration, finger amputations, putting in radial ulnar median blocks, hip fractures, femoral nerve blocks, and to be able to have that toolkit to help the patient, right, alleviate a lot of their discomfort when they're being transferred down to see orthopedics down in Trail can be really, really handy.
So how many times a shift, or like what percentage of the patients that you see do you end up using the ultrasound for?
Yeah, it's hard because it's quite variable. I'd say on the quarter of my 1/4 of my patient interactions, so 5.
So do you see any big new developments right around the corner in the land of ultrasound?
Not particularly. AI, we talked about the handhelds. I think one of the main things is you mentioned it earlier. It's going to be the integration, right? And for years, we've been talking about the integration curve and how we were initially early adopters. But like you said, Jim, it's going to get to a point where everybody is using it. They're starting to finally uh, add more training in the undergraduate program at UBC in terms of medical schools. Same with residency. The program that they've just developed in this last year is far more robust than what we were doing 2 years ago. So it's just going to become more and more commonplace. And I mean, ultimately, it'll take a a number of years, but I see it phasing out the stethoscope essentially.
Yeah, I mean, no argument there. Hey, Kevin, I just want to say you've been a super guest. Thank you for being here with me. I know that you've got to work and you've got the afternoon evening shift in just a few hours. I really wish you the best on that shift, and thanks for sharing everything with us today. Have a super time in the hospital this afternoon.
No hip blocks.
Hey, may no one break their hip in the Nelson zone today. Hey, audience, I want to hear from you. What do you think about today's episode? And what ideas do you have for future episodes? Hit me up, connect at jimweidrich.ca.